Hello and welcome. I'm Jeunesse Castonguay, VP at Clarius. We're thrilled to see so many of you join us here today, some of you new to the series and some returning. You're among 3,500 clinicians who registered for today's live webinar, Cardiac POCUS Part 2, Techniques for Assessing Right Ventricle Function. Pulmonary emboli and other causes of right heart strain lurk on the differential diagnosis for most patients with chest pain or dyspnea. Relying on standard blood testing and radiography protocols can delay diagnosis, leaving patients without what can sometimes be life and function-saving treatment. A quick point-of-care ultrasound exam can make all the difference. In a moment, emergency physician and ultrasound educator Dr. Tom Cook will join us and present several cases demonstrating how to use point-of-care ultrasound to assess right ventricle function to quickly, accurately, and reliably determine whether the right ventricle is showing signs of dysfunction or increased pressure. You'll learn practical POCUS skills you can use on your next day in the emergency department, hospital ward, or intensive care unit. You can use the questions icon at any time during today's session to ask questions. Dr. Tom Cook will address your questions in the live Q&A following the presentation. Let me now introduce you to our host for today's webinar. Dr. Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as chairman of our medical advisory board. Welcome back, Dr. Frankel.
Hi, Jeunesse. This is great to be back on a topic that's near and dear to my heart and something I probably use every day in my emergency practice. To set the stage for our deeper dive and discussion today, we did a quick literature review, and I wanted to highlight a few of the articles that came up. The first one is that the tricuspid annular plain systolic excursion, or TAPSE, which you'll be hearing much more about, is a validated echocardiographic marker in the severity of right ventricular strain. And what this study really backed up for us is that emergency physicians like you and I, with some echocardiography training, can reliably measure and calculate the TAPSE. And we'll get into the weeds and details pretty soon. You know, the next study, though, is even better, that beyond just measuring, we have good data that shows in this observational study that we can visually estimate the TAPSE, like many other echocardiographic things that we look at in the emergency patients. In settings where it was obviously either completely normal or severely diminished, a qualitative assessment may suffice in making the clinically oriented observation on the TAPSE measurement. And, you know, lastly, was something that really came up and was solidified during the COVID-19 pandemic, that in our critical care wards, especially, point-of-care ultrasound provided a valuable adjunct tool in patients with hypoxemia and or dyspnea in trying to determine the pathology present, whether it was due or related to their pneumonia or other potential causes. And it goes way beyond just pulmonary embolism to a much broader cause and differential diagnosis of why our patients are decompensating. And so before we get into the nitty gritty here, we wanted to just put up a poll. We know we have people from all over the world at various levels of practice. How frequently are you using ultrasound to assess right ventricular function? Is this something that's new to your practice and you're just learning today, something you occasionally do, or are you like me and maybe a daily user of these kinds of studies? And since it's a quick one answer, we'll close it pretty quick here just to see where people are at. Great, and we've got across the board. It's great. So a full third are just learning today, which is fabulous. And there's a third who are already pretty proficient. So I think you'll agree at the end of the webinar that everyone has learned something from our great guest speaker. And we can't think of anyone to bring back better than Dr. Tom Cook, who came to Palmetto Health after leaving the Army Medical Corps in 1996. And he trained in emergency medicine at Fort Hood, Texas, before taking on a rugged 3-year tour at Tripler Army Medical Center in Honolulu. After leaving the Army in 1996, he joined the emergency department staff at Palmetto Health, where he initially developed the emergency ultrasound curriculum and then founded the nationally recognized Third Rock Ultrasound and the emergency ultrasound course, where he's been the program director since 2001. In Palmetto. Dr. Cook, we're going to hand it over to you. Great to have you back.
Thanks, Ron. That was a wonderful introduction there. Of course, this is a fantastic topic to get into, as you alluded to just a moment ago. So let's go ahead and dive right in. But before I hit the actual subject matter, let me just do a quick plug here. You mentioned that I teach ultrasound, and this is our program, Third Rock Ultrasound. And I'll tell a little bit more later about some upcoming opportunities. But this is a course we formed 25 years ago, 1998. And we've just had a tremendous experience with it. And we have some exciting opportunities coming up in the near future. Some of the viewers would like to join us. That being said, the objectives for our session today are four. We'd like to, first of all, understand what the causes of elevated right heart pressure are. Then we'd like to be able to identify that using ultrasound. We'd like to learn a little bit about quantifying pulmonary artery pressure. And finally, we'd like to quantify right ventricular dysfunction via this method you just mentioned called TAPSE. But we'll start out with a case. All these are cases that I've seen in the emergency department over my career. And this was a woman who showed up who said, gosh, I'm short of breath. I have this chest pain. And I just got discharged from the hospital down the street. I spent a week there. They did all these tests. They said they didn't know what was the matter with me. And so I left there and came right over here. Maybe you guys can help me. And in the course of her immediate evaluation, of course, we get some vital signs. And we notice, hey, her blood pressure is kind of high and her oxygen saturation is a little bit low. So that's a little bit concerning. And then at triage, she gets a bunch of labs ordered. And all those look fine. We get sort of the usual suspects. We get the troponin, we get a BNP, that type of thing, a D-dimer. Nothing really comes up positive there. She also has an EKG done. And you can see the tracing here, and it's a normal sinus rhythm, P's before Q's, narrow QRS. But there are a couple interesting findings on here. One of those is that in the precordial leads, the QRS tracing in V2 and V3 are quite a bit bigger than V5 and V6. And also that she has a right axis deviation as well. So that's a little abnormal. I don't know that everybody would suddenly, jump to a conclusion based on seeing that on EKG. You look at so many of them, but that was a little bit interesting. So immediately we go to ultrasound, which is, of course, the point of the conversation today. And this is an apical 4-chamber view. And it doesn't take a genius to go, wow, that looks pretty weird. What's going on here? The right side of the heart looks way, way bigger than the left side of the heart. There's something that's very, very strange here. And if you look at the right ventricle, you can see that it is dramatically larger than the left ventricle. In fact, the left ventricle looks pretty small and it has an ejection fraction, which is approaching 100%. It looks like it's squeezing out every last drop. The other thing that's kind of interesting too is if you look at the left atrium, it is very, very small. It's almost obliterated. That's kind of interesting as well. And finally, if you look at the free wall of the right ventricle here, it doesn't seem to contract very well. So those are all things that maybe you wouldn't pick up on first blush, but when you look at it, those things become much more apparent. Now, anytime you see some sort of abnormal anatomy of the heart, the one thing I want you to stick in your head, well, a lot of things, but one more thing I want you to stick in your head is that there's almost always going to be some sort of valvular abnormality. There's going to be stenosis or there's going to be regurgitation. And I just want to stick that thing in your head because we're going to get at that in just a second. Now, our next slide here is a comparison of this patient's heart on the right with a normal heart on the left. And boy, it's really, really easy to see the difference now, right? The right ventricle is much smaller in the normal heart than in the abnormal heart. So, and also look, you can see the left atrium very, very easily in the normal heart where, you can barely see it all in the abnormal heart. Now, I mentioned this thing where you have some sort of abnormal anatomy and you should stick it in your head. Gosh, there's got to be a valve problem here somewhere. Something's got to be going on that I wouldn't expect. And so one of the things we'd like you to do when you see that is just put some Doppler over the valve that's involved with this. In this case, it's the tricuspid valve. And very, very easy to see that this patient has tricuspid regurgitation. So we've already picked up a few things that are concerning with this particular patient. And we've probably spent, 30 seconds at time. Now, we see this tricuspid regurgitation and we say, can we quantify the amount of tricuspid regurgitation? And you can by looking at the color Doppler pattern over the valve that you're looking at or the valve that's in question, in this case, the tricuspid valve. Now, just a couple things about color Doppler. One of those is that understand that if the blood is flowing in certain directions, you get certain colors. So if the blood is moving towards the transducer, it's given a red color. And if it's moving away from the transducer, it's given a blue color. And this is confusing. Sometimes when people first time they turn on color, they think, oh, if it's arterial, it's red. If it's venous, it's blue. That has nothing to do with it whatsoever. It has to do with is the blood moving towards or away from the transducer. So when you look at a pathologic flow across a valve, there are three areas that we have to focus on. And the first of those is that area just before the valve where you see the sudden acceleration of the blood, because within that color box, that color Doppler box, it's only going to look for blood that moves a certain speed. It's not going to look for blood that moves at a normal speed. It's only going to look for blood that's moving at an accelerated speed because of some type of pathology. In addition, as the blood starts to speed up, it goes from a very, very dark color to a very, very bright color. And at some point, it hits something called the Nyquist limit and actually flips color. So if it's going away from the heart and everything should be blue, if it hits a certain speed, it'll actually flip colors and go yellow or even red. And we can actually see that on the left. This is actually a case of mitral regurgitation, whereas it just gets through the pathologic area of the valve, it flips color and it goes from blue to yellow. So the size of this area, and right here, this is called a flow convergence zone. The bigger it is, the more pathologic it is. Now, the second thing you're going to look at is the actual defect in the valve and the size of it. And this is called the vena contracta. And, this is a grading scale here to say, if it's less than 3 millimeters, it's not so bad if it's greater. But you don't need to remember this. All you need to kind of do in your head is think, is this thing pretty small or is it pretty big? You can see on the right side, it's pretty small, and it's not that pathologic as compared to the left side. Now, the third thing that we would look at in this color Doppler pattern of pathology or flow pathology across the valve is the one that sticks out. This is like the rooster tail, and this is called the regional jet area or just the jet. And it goes to reason again that the larger it is, the more pathologic it is.
Would you say that I'm not good at measuring the width of the jets, but kind of the bigger size compared to the valve itself, when it's a wide jet, I'm going to consider it's more severe regurgitation. Exactly. And also to the extent that it starts to fill up the chamber. And if you do this enough, if you just look at enough valves, the most common valve pathology you're going to see is mitral regurgitation. Everybody with, hypertension for a decade or so, they're going to get a little mitral regurg. Heck, I got some. And you'll see it, but it's just a little bitty color Doppler signal. And so as you start looking more and more, you'll see some big ones and you'll be able to appreciate the difference. Now, the other thing besides just the size of the jet is its location. And if the jet is actually running down the side of the chamber, eccentric off the center, that's a higher degree of pathology. And we see an example here on the left where the jet is centrally positioned. It's almost perpendicular to the valve. This is a lower level of pathology than what we see on the right, where it's actually coming off eccentrically and it's hugging the side of the valve. And when it does this is something called the Coanda effect. And it's an indication that you have a higher level of pathology, in fact, a very high level of pathology. Now, we can see in this diagram how that actually works. So the jet is moving along a smooth surface, and there are electromagnetic forces that are allowing it to attach to that surface. And what happens is that as the jet moves along and it encounters a curved surface or curved area on that surface, it'll follow the surface away from the original direction it was moving. Now, the important thing you have to remember is that only happens when that jet is moving really, really fast. And if it's moving really, really fast, that tells you that you have a higher level of pathology. So you can see it in this example here. In this video, there's a fan that's blowing air parallel to the floor. But of course, it comes across a curved surface. And so once again, the Coanda effect occurs and the wind actually blows down. And you can see that with the toilet paper here. We would predict it would blow out parallel to the floor, but in fact, it's hugging that curved surface and it's moving down towards the floor. That's the Coanda effect. So here we can see it in our patient that we just had in our case. And we see that, yes, she has some tricuspid regurgitation, but when it's moving like that, it's a little hard to figure out. So what you got to do is hit the freeze button and then go through the cine loop to actually get a good feel for how big that is. And so you see that here, where you get a nice view of the convergence zone proximal to the valve, and it's pretty big. And also the vena contracta is pretty big. It's pretty large as well. That's a pretty big defect. So those are two things that are telling you got a moderate to severe level of pathology. And then if we just move one more frame, we say, geez, that jet is also pretty big. It fills pretty much the entire chamber. It's not eccentric, it's centrally located, but it fills the entire chamber. So that gives you an impression on this patient that you have
a moderate to severe level of tricuspid regurgitation and valve pathology. And what you can do with this is look at that color Doppler pattern, and this will give you an estimate of the pulmonary artery pressure. How high did that pressure get to create that elevated pressure gradient on the right side of the heart and create that valve to start to fail, where you get tricuspid regurgitation. So when we summarize our findings on this patient just by looking at her with ultrasound, and mind you, you're doing all this within maybe 60, 75 seconds. This does not take a long time. We know she has an enlarged right atrium, an enlarged right ventricle. She's got a moderate to severe amount of tricuspid regurgitation, which means she has an elevated pulmonary artery pressure. She has poor right ventricular wall contractility. And most important is that she has a very small left atrium and small left ventricle. So there's something going on here in the right heart that's not going on in the left heart. This is isolated right heart failure. Now, what's causing this? Why would you have isolated right heart failure? And I'm going to make a quick point that goes across anything you do with echo. And that point is that heart structure is enlarged because of pressure. And if you can figure out where that pressure is coming from, you're going to be able to make the diagnosis. So if we think about the different causes now of elevated right heart pressure, by far the most common, we all learned this in medical school or, whatever type of a healthcare professional you are, we all learned that the most common cause of right heart failure is left ventricular failure, left heart failure. However, this is the most common chronic cause of right heart failure. We also learned that the most common cause of acute or sudden right heart failure, of course, is pulmonary embolism. And these are the really two bad actors that you'll see most of the time clinically. But there's a list of other things that can occur, right? So isolated pulmonary hypertension, which could be idiopathic, could be pulmonary fibrosis, could be a COPD, a number of different things. And you can also have right ventricular infarction and pulmonary valve disease. These are pretty rare, but they do occur. So you have to kind of keep them in the back of your mind. Now, in our patient, we know the right ventricle is large and the left atrium is small. So if we think about this anatomically, there has to be a block somewhere between the left atrium and the right ventricle. And if we assume that she doesn't have pulmonic valve disease, like pulmonic valve stenosis, we pretty much are going to understand that the block is coming from the lungs itself. And so what we have is the ability to make our diagnosis that she has chronic pulmonary hypertension. And the real pathology that we need to find here is in the lungs. Now, unfortunately for chronic pulmonary hypertension, it's a cruddy disease to have because it's really hard to treat. You can give them some supplemental oxygen. There's some medications like sildenafil and some other things, but there's no surgical option, and they tend to have a pretty lousy prognosis. And I've made this diagnosis 25, 30 times over the last 10 years, and they tend to be pretty sad cases and very unfortunate patients. Ready to move to our next case. This is very, very unusual. You never see this guy clinically. This is an old guy that says, I can't breathe. This never happens, right? Old people say they can't breathe. Good Lord. Oran, you seen any of those lately? Anybody in your...
No, not in the past couple of years. I mean, I don't know.
Crazy diagnosis, crazy problem, right? So here's an old guy. He's got a history of hypertension. Again, who has this? I don't know. He's short of breath, and it's been worse for 3 days. Wow, that's interesting. And if you look at his vitals, his heart rate's fine. He's probably on beta blockers. His respiratory rate's a little high. His blood pressure's a little high, and his sat's a little low. So yeah, this is a dime a dozen. You see these guys all the time. And you get your EKG, and it's a sinus rhythm, P's before Q's. The QRSs are really big in the precordial leads. Of course, this makes you think of ventricular hypertrophy. And he's got that strain pattern, that classic strain pattern in the STT wave segment across the precordial leads, particularly V1 through V3. So these are all tip-offs to make you start thinking. But, you can also go get an ultrasound. Now, of course, we covered this in our last seminar back in October with looking at left ventricular failure. And the first thing I always tell people, or I ask the students when they're looking at this, is what's too big? And it's pretty easy to see here. The thing that's too big is the left atrium. As a rule of thumb, the right ventricle, the aortic outflow tract, and the left atrium should all be roughly the same size in a parasternal long axis view. And clearly the left atrium is just too big in this situation. And if you remember from our last webinar, We can look at some other things to look at left ventricular function as well. The mitral valve excursion is poor. We don't see that the anterior leaflet reaches up to touch the interventricular septum. We have very poor fractional shortening, which is the axial dimension of contraction in the left ventricle. And finally, when we look down at the mitral valve annulus, it doesn't move very well at all towards the apex of the left ventricle. These are all things that tell us, hey, we got left ventricular failure going on here, which, we kind of suspected anyway, based on this guy's presentation. Now we're going to move over to the apical 4-chamber view. And again, we'll play this game. What's too big? Well, these two atria look like a pair of coconuts. They're just gigantic. They're as big as the ventricles. And so what did I tell you before with the heart? Anytime you see something's too big, there's too much pressure somewhere, right? There's way, way too much pressure. And also what I told you early on in this thing was, hey, if you see something wrong with the heart, it anatomically is not normal. You're going to have a valvular problem, guaranteed. So what are we going to do? We're going to turn on the Doppler, right? We're going to turn on that Doppler. And the first thing we'll do is we'll go ahead and stick that over the mitral valve. And when you look at that, you see some pathology, right? You see a little bit of mitral regurg, but we can tell without even freezing it. This is just a little dribble. This is not that big of a deal. It's very, very small relative to the first case we looked at. So why don't we go look at the right side of the heart and see, whoa, look at that thing. That's a monster, right? We don't even need to freeze that rascal. That's a lot of tricuspid regurgitation going on there. Big convergence zone, big vena contracta. The jet fills the entire right atrium. That's a lot of tricuspid regurgitation. So we know that this guy has not only left heart failure, because we looked at that plaques view, that peristernal long axis view, but he also has right failure with that big, gigantic tricuspid regurgitation. And so a management for this is stuff that we always do: some oxygen, some nitrates to decrease preload, some diuretics, and most importantly, I didn't put on this, but we need that BiPAP out, and we need to probably get this guy admitted. All right, let's move on. Next case. Our next case we're going to call snake in the grass, because it is a snake in the grass. It's the one that always comes up and bites you. It certainly bit me pretty bad a few times. But this is a young guy who comes in and he's been throwing up all night. He doesn't have any chest pain. He says, I'm a little short of breath, but he said he got into something, he had some leftovers and he threw up all night.
It's the tuna sandwich. It's the tuna sandwich.
It's always the tuna. It's that commercial where the guy opens up the fridge in the middle of the night, smells the food and goes, okay, I'll eat it. Shouldn't have done that. And anyway, so we get our vitals. We say, wow, he's tachycardic and his blood pressure's a little low, but he was throwing up all night, right? He's been throwing. He just needs some volume. He's a little tachypnic and his sat's a little low. Well, we wouldn't expect that. So we get our EKG and we see that he's in sinus tachycardia. We see P's before Q's. We see a relatively narrow QRS. But there's one interesting thing, they always kind of, the cardiologists love to bug us about it, kind of look out for that. And that's this guy's got an S1 Q3 T3. And so about 15% of the patients with pulmonary embolism, they have that thing, right? A terribly insensitive test, but it's there. Let's not dismiss it. So of course, what are we going to do? We're going to ultrasound this guy. And in this peristernal long axis view, the first thing goes, whoa, what's going on with that right ventricle? That thing's just huge, it's really, really big. Big as a hockey puck for you Canadians. Big as a hockey puck. We wouldn't say that down here in the southern United States. Big as a hockey puck. And what's going on in that left ventricle? My goodness, it's squirting out every single ounce of, every red blood cell it can. It's actually collapsing in systole, right? It squeezes everything out. So the heart's doing everything it can. Remember, this guy had some hypotension. So the heart's doing everything it can to try and keep that pressure up by maximizing cardiac output. Now, we go ahead and look at the peristernal short axis. And once again, we're impressed at the size of that right ventricle. It's bigger than the left ventricle, a lot bigger. That poor little left ventricle, he's all squished in there. He's having a tough day. Now, we'll go ahead, of course, go to the apical 4-chamber view, and we see this again, this really big right side of the heart, that really big right atrium. And we see, of course, on the left side, we barely see a left atrium, and the left ventricle is doing everything it can to squeeze out every little bit of blood. So we know, what do we do again? When we see some abnormal anatomy, we turn on our color Doppler, and well, the tricuspid regurgitation looks like a volcano's erupting there, right? Yeah. This is massive. So once again, we know we got a big right heart problem. We know we got a jacked up pulmonary artery pressure. And it occurred suddenly. This wasn't something that this guy had been having for weeks or months or years. This came just about overnight. He's a healthy guy.
Hey, Tom, was that some coanda happening there?
A little, but the whole left atrium is just jack full of blood.
Yeah.
So it's a little hard to tell.
Yeah.
There is a little coanda in that one, but you don't even have to be that sophisticated. You just got to go, whoa, that's a lot.
I'm just trying to sound sophisticated. Yeah.
Yeah. Well, it's always good, but this is one where you can just look in and go, that is a whole lot of tricuspid regurg. And of course, this guy has, gigantic pulmonary emboli. And so now we have to go ahead and save his life. So remember, this case started out as just a guy who had been throwing up all night. We were going to give some fluid. And now, after just an initial evaluation and, 2 minutes of ultrasound, we realized this guy's in full-blown shock and we have to do something dramatic.
How did the tuna sandwich give him massive PEs? I really want to know.
Right. Beware the tuna. That's, I think, one of the teaching points of this seminar is beware the tuna. Now, how are we going to manage this guy's hypotension? Originally we thought vomiting, we're going to give this guy some volume. We're going to make him feel better, give him some Zofran. He's going to stop vomiting, whatever. And so the question is, should we be giving this type of patient, IV fluids? And so to illustrate why we need to be careful about this, we're going to look at a different case. This is a 41-year-old woman, and she has syncope at work. Again, crazy. We never hear about this. People having fainting. I don't see this stuff. Fainting? Are you kidding? Anyway, EMS arrives. Somebody hits the panic button. They call paramedics. They say, oh, look at that sinus tachycardia, 130. Blood pressure's pretty soft. What are we going to do? Well, we should probably give this lady some IV fluids because she's got low blood pressure and tachycardia. And they do that. And after about 500 cc, she goes into cardiac arrest and they start ACLS. So when she gets to our place, she's still in PEA. Now let's think a little bit about what happens to the heart when you have a pulmonary embolism. When you put that block in there, of course, the blood cannot go from the right side of the heart to the left side of the heart. So the right side of the heart gets really, really big, and the leaflets of the tricuspid valve separate, and that's why you get that tricuspid regurgitation. And what do you think would happen if you already have an enlarged right heart and a compressed left heart, and then you give a bunch of IV fluids? So to illustrate that, this is the echo from that patient. And it's a low quality echo. It's an older study. And you can see that the heart ain't beating so well. She's a PEA. And you look, the right heart's gigantic. And you see a bunch of bubbles in there. Now, that's just IV fluids. Anytime you give IV anything, there's a few bubbles that float around in the right side of the heart. Don't worry about that. This is not pathologic air embolism. That's just there's some stuff in there. You don't have to worry about that. But it does bring home the point that by giving this patient IV fluids in the face of a massive pulmonary embolism, you have literally cannibalized her left ventricle and squished it completely, and she has no cardiac output and she dies. I mean, that's just actually what happened. And it's tough. I mean, the paramedics were just following their algorithms, but this is a situation where that needs to be identified, on the front end. This may be future, for paramedics, that we train them how to do this and say, big right heart, maybe not do that. So what do you do in the face of somebody who has, massive pulmonary embolism causing shock that you've identified by ultrasound? Well, we have to give drugs. When you have shock, you got two choices. You give fluids or you give drugs. And we have to use drugs for this situation. And we have to use this cocktail of 3 different drugs. So the first thing we do is to support systolic blood pressure, right? And so the go-to drug now is Levophed or norepinephrine. Or I don't remember if you're old enough, but we used to say Levophed, leave them dead. Were you part of that generation?
No, I came on where now Levophed is your one-stop shop for everything.
So when I was early on, this is in the late 80s and 90s, nobody wanted to use norepinephrine because we thought it killed everybody. So, we also didn't give antiemetics to children who were vomiting. We thought we would kill them with that. This is how stone age it was back in the day. Anyway, so we're going to give some of that Levophed to not leave them dead. We're going to keep their blood pressure up. The second thing we want to do, of course, is stop the clots. So we're going to give them some heparin. We're not going to give them a little bit of heparin. We're going to give them a lot of heparin. Okay. So 5,000 units, if you're just, spitballing it, or weight-based, whatever, you're going to give them a lot of that stuff. Okay. And then we got to bust up the clot. And, this is somewhat, geographical and institution, but I'll get into our regimen in a second. Or we send them to interventional radiology and we scoop that clot out of the lungs. And this is pretty cool if it's business hours and you got a team that's ready to do it, we do that. And this is just an example of that from our place. And this is just pretty awesome. Look at this rascal.
Can you take a photograph of that?
That is a massive clot.
Wow.
Yes, sir. Got it.
It looks like a snake. Anyway, remember, it was snake in the
grass.
grass is the name of the case. So that's the snake in the grass right there.
There you go.
And so, you pull out that clot and you save this person's life. This is pretty cool stuff. We don't always get to do that. So here it is. Here's your 3 drugs: norepinephrine, lots of heparin. And the one that's approved in the States is Alteplase, or TPA. It's a 10-unit bolus and the 90 units over 2 hours. But I've had plenty of cases, you put it in, the patient goes in PA, and you just squeeze every single shred of TPA in them and try and do something. And then there's also tenecteplase, which is really nice because it's just a single shot. You don't have to do the bolus and the drip and all that. What do you use at your place?
TPA, Alteplase, yeah.
Yeah. But you can have some impressive saves from this, from people who are literally like dead, near dead, kind of dead, whatever. So there's also this idea of submassive PE. And the way I choose to define this is you have a pulmonary embolus, you've identified that by ultrasound and you have it, but they don't have a lot of hypotension. And in this situation, the thrombolytics become somewhat controversial. So at my hospital, we have a PERT, P-E-R-T team, which is pulmonary embolism response team. And so when we get in these situations, we call the PERT team in, and they get all the heads together and make a decision about whether they're going to use TPA or not. And I let them worry about that if I can. But if they're clearly hypotensive and dying, I'd give the thrombolytics. So, and this is a busy slide. You don't need to remember this, but this is all, the absolute contraindications and relative contraindications to thrombolytics. I have to look them up. I don't remember all this stuff. I'm old. But just so you know, they're out there. Now, we're on to the last part of this talk, and that's just pearls and pitfalls. There's always some in there. So one is, can I measure right ventricular myocardial function? How well is the right ventricle pumping? And you can with this very easy tool. We already mentioned it before. It just takes a minute or so, and it's similar to what we learned in the seminar on left ventricular function, where we looked at MAPSE, which is the movement of the mitral valve annulus towards the apex of the heart as you go through the cardiac cycle. But now we're just going to look at the tricuspid valve. So it's TAPSE, tricuspid annular plane systolic excursion. That's a mouthful. Just say TAPSE. And what we're going to do is think of the right ventricle as a cone, in that the tricuspid valve is at the base of that cone. And that tricuspid valve is held into place by an annulus, which is a much more stiff, fibrous structure, which is very echogenic. Remember, things reflect ultrasound if they have no density, or they're more stiff. They have less flexibility, and the annulus is quite a bit more stiff than the myocardium, so it's easy to pick up. And what we want to do is see how that tricuspid valve annulus moves towards the apex. So the apex, particularly on the left ventricle, doesn't move very much. On the right ventricle, it kind of rotates. But anyway, just think of the apex as being it stays in one place, and that the annulus moves towards the apex. And we can see that here, how to do this. So we get an apical 4-chamber view, and we'd like to be able to see the tricuspid valve annulus, as well as the free wall of the right ventricle. And then we put our M mode cursor so that it's moving through the tricuspid valve annulus. And then we go ahead and turn on our M mode, and we get that tracing of the movement of the tricuspid valve annulus as it moves towards the apex and away from the apex. And we get this waveform, and then we just measure that distance, and it gives us an indication of how well that right ventricle chamber is functioning. So here we can actually see it in real time. We've identified the right ventricle, and then we'll go ahead and turn on the M mode cursor and place it through the annulus. We get this beautiful tracing here of the annulus, very, very clear. And we can see when we measure that, it's a little over 22 millimeters. Now, is that good or bad? That's actually very good. So for a man, anything equal to or greater than 18 millimeters is normal. And for a woman, it's 15 millimeters. Let's look at a different one. So here's one where maybe the annulus doesn't move quite as well. And what we can do with this, of course, is put that M mode cursor through there, go ahead and get our tracing. And then when we measure this, we see it's only around 9 millimeters. So this is abnormal, regardless if you're a man or a woman. And so this is somebody who has decreased right ventricular function. Super easy to do this. I mean, it's like a minute of your life, and it gives you a lot of information very, very quickly. Keep in mind the TAPSE and MAPSE are not the same, okay? TAPSE, the normal values are about 1.5 times greater than MAPSE because the right ventricle rotates around the left ventricle in the cardiac cycle. So there's much more movement of the tricuspid annulus as opposed to the mitral valve annulus. Okay, that was pearl number one. Number two, can we just look at the right ventricle and say it's normal? Well, this is really easy to do. The apex of the right ventricle is very, very pointy. It is normally very pointy, particularly when you contrast it to the apex of the left ventricle. So you can look for that pointy apex of the right ventricle. It tells you that is pretty normal. Here again, look at the left. That's normal. That right ventricle is very, very pointy. But when we look at the pathologic case on the right, you can see it's not pointy at all. It's very, very rounded. So that's a good indication you have right ventricular problems. Third pointer. Look at the actual right ventricular wall. It has changed in response to elevated pressure. And remember again that anything that gets big in the heart, I'm not just talking about chamber size, I'm talking about the thickness of the actual walls of each chamber. When they get thick, that's in response to chronically elevated pressure. And here's an example of you've got somebody with this really, really thick right ventricular wall. I tell you, that's not a pulmonary embolism. I mean, that didn't happen yesterday or in the last few hours. That's been going on for a long, long time. So that's, again, a tip-off that you have something wrong there where that wall is just so thick. Another thing on this case kind of interesting is you can see this sort of funny appendage here coming off the right atrium. Originally, I thought, well, is this the left atrium? It looks kind of weird. And why is there a space between that? Is there some sort of weird atrial septal defect going on? But I had to go back and think about my anatomy and figure out, well, what is it that actually attaches to the right atrium at that particular point? And I finally figured out that this is the coronary sinus. So the coronary sinus is the venous counterpart to the coronary arteries, and it collects all the blood that's going through the myocardium, and it dumps into the right atrium. So that thing that was attached to it was the coronary sinus. Of course, it's not normally that big, but it had been under such chronic long-term pressure that it has just enlarged in size tremendously. So sometimes you'll pick that up. You can normally see the coronary sinus if you get pretty good at ultrasound. It's pretty easy to pick up a normal one, but that was clearly abnormal. Okay, fourth pointer here. What else enlarges when you have right ventricular pressure elevations? Well, we already know that the right atrium enlarges. You can look at this one. That's just massive. But don't forget to also look at the inferior vena cava, see if it's unusually stiff. And in this case, too, look at that hepatic vein. That's all dilated. So that does give you a very good indication. Sometimes maybe you can't even get a view of the heart and you're struggling for whatever reason. But if you look at the IVC, you know there's some sort of pressure and it's really, really stiff and the hepatic veins dilated. That gives you a tip off. Okay, there's some elevated pressures in the heart, particularly on the right side of the heart, that I need to be aware of, even though I can't see it. Number 5, this is the D sign. This is a situation where you've got 3 cases all in a row, and they all show the same thing. The right ventricle is really, really big in all of these cases, and the left ventricle is really smushed down. And when you see that, the septum, the intraventricular septum, flattens out, and it takes on the appearance of the letter D. And you can see that right here. And this is the D sign. And this is, again, another tip that right ventricular pressure is very, very elevated, and it is starting to push down the septum instead of normally allowing the left ventricle to be round.
The normal on the short axis, we always call it the donut and the croissant, so that the LV should be the donut, nice and round. You don't want a squashed donut.
Right. We don't want to squash the donut. And we say croissant in reference to our friends in Quebec. Okay. And anybody who happens to be in France. All right, let's move on. Number 6, this is just sort of a warning. You can get burned on this. I have in the past. Bear in mind that small pulmonary emboli are not going to cause any changes in the heart. Okay. They're just not going to show that. These little things that spit out once in a while. So, you have to keep in mind, we've got some clinical tools that will allow us to to figure out, or at least risk stratify these patients, things like PERC and the Wells criteria. Here's all the PERC criteria where if they have any of these, you can't say they don't have a pulmonary embolus, and the Wells criteria. So a lot of times where I get stuck on the PERC is they're over 50. And I think, well, I don't know. It just doesn't seem right. It doesn't seem like that's the diagnosis. So I'll go over to Wells and go, well, I look at that and maybe it makes me feel a little bit more comfortable. But, you got to have a little clinical acumen as well. And, if one of those things come up and you get down the decision tree far enough, maybe a D-dimer is positive or whatever, then, you got to scan them. In the old days, getting a CT scan was like an act of God, and now it's like a chest X-ray. We do them all the time. At least we do in the States, because we have to bill the patients a lot of money. So number 7 is just the uh-ohs. So, you're cruising along, you're minding your own business, and something like this comes up and you go, what the heck is this? I mean, look at the right side of the heart. It's just bizarre. It's like 3 times the size of the left. And you really don't know. So again, like I told you in the beginning of this thing, when you see something weird anatomically, turn on the Doppler and, you might find out something that really helps you out. And that was the case in this one. We turn on, look at that turbulent flow. It's just massive. And the reason is that this is actually the tricuspid valve up here. And what you see here is just the jet filling up the entire gargantuan right atrium. And then when you look down here, you see this thing floating around. That turned out to be the pulmonary embolus. So we tend to think of pulmonary emboli as maybe these globular things, but they have all sorts of weird shapes and everything else. And so this was a case of pulmonary embolus, but I think it had been recurrent emboli, because I can't believe that the right atrium got that big. But that was just a case, you see something weird, you see something bizarre. Don't forget to use your Doppler. Here's another one. We look at this case, and if you look at the right side of the heart, again, big, but look at the embolus just attached to the valve, or rather the thrombus attached to the tricuspid valve. And it's just flopping back and forth between the right atrium and the right ventricle. And this was like, oh my God, give this guy some heparin right now. Because if that thing snaps off, that might be the last straw. So sometimes you'll run into these. This one's really obvious. I mean, that's just a big meatball sitting on the tricuspid valve. It almost looks like it could be endocarditis, but this was the case. And these are old cases. You can see they're kind of grainy images. These things don't come along every day. So when you see one, you gotta quickly stick it on and save it in your files. But this one here, again, watch out. That could be a widowmaker.
Yeah, I would say myxoma would also be on that list. Once in a while, you'll see one.
Yeah, that's a good point.
It's a clot or something.
Yeah. That one turned out to be a clot, but myxoma was excellent thought there. All right. Final thoughts. Look at the right heart. That's the first thing. We all pay attention to the left ventricle, and for good reason. But look at the right heart. It gives you a ton of information. And you really, once you get past looking for left ventricular dysfunction, you got to be looking over for right-sided problems. Remember to not just look at the right ventricle, but look at the right atrium. Look at the IVC. IVC is always a nice tip there. Understand the different parts of the color a Doppler pattern in valve pathology, and use that to quantitate the degree of valve pathology. Remember, TAPSE, super easy thing to do to give you an estimate of right ventricular function. All right, one quick shameless plug from me, and my part here is largely done. So Third Rock Ultrasound, doing courses again for 25 years. Our next course will be in my hometown, Columbia, South Carolina. We'll be there in April. From April 26th to 27th is our introductory course, and on the 28th we have an advanced course. If you're interested, go to thirdrockultrasound.com. We'd love to see you attend one of our meetings. And I think that's it. So thanks so much. I had a blast, and I guess I turn this back over to you, Aran.
Yeah, sounds great. Thanks so much, Tom. Please keep we have a lot of questions flowing in, so please keep adding questions to the Q&A. We will get to them very shortly. Before we get there, we're going to hand it over to Shelley Gunther, our clinical marketing manager, for a demo.
Thanks, Aran. Great talk, Dr. Cook. Beautiful imaging, as always. I'm just going to switch over my camera here.
So I'll chime in. That our first webinar with Dr. Cook was left ventricle. And, it's not really a separate exam to do the right ventricle. So, inclusion criteria is really any patient with chest pain, dyspnea, hypoxemia, anything where you might worry that the heart or lungs are involved. A quick scan can really help focus the differential diagnosis.
All right, so just make our way over here. And I've got my patient in the left lateral decubitus, and I'm going to scan with my right hand today. And I'm actually going to start in the parasternal long axis view. Turn my gain up a little bit here. And right away, we can see what Dr. Cook was talking about on the parasternal long axis. We can look at the right ventricle, the aortic root, and the left atrium down here. And they're all on our patient essentially the same size. So right off the bat, we're not concerned about right ventricular decrease in function or an increase in size. Now, a little tip that I will show you as well is if I point the scanner down toward the patient's right hip, it actually takes me right into the right ventricle here, and I can see the tricuspid valve. And this is often a really, if you can get a nice parasternal long axis, this is a great way to look at the right atrium and right ventricle and the tricuspid valve. And at this point, we can actually turn on our color Doppler and look for any tricuspid regurg here.
We call it the tail up from the parasternal, just sort of lift the tail of the probe up a bit.
Great. Now our patient doesn't have, maybe has a little whiff of a tricuspid regurg that pretty much everybody has on the planet. And I'm just going to go back to, we have a new 2D button that I can go right out of the color Doppler and back to 2D imaging. Great. And then from here, I'm just going to go down to the apical 4-chamber view. And again, right off the bat, we can quickly assess that the right ventricle is a little bit smaller than the left ventricle here. The shape, the apex is more rounded, as Dr. Cook talked about, whereas on the right ventricle, it's a little more pointed. I can see that the tricuspid annulus is moving very well. But if we wanted to, we could go into M mode and drop our cursor through the annulus. And then on this side, we can see that we're getting really nice excursion of that mitral or that tricuspid annulus. And I don't even really have to measure it at this point. If we wanted to do that, we could go into the measurement tools and measure our TAPSE here.
Nice. Yeah,
well,
I love the eyeball. Yeah.
Yeah. Just makes sense, right? And then 2D again, just to get out of that. One thing that can kind of trick you up a little bit is when you get toward the apex, not too prominent on my patient, but oftentimes you'll see a band that goes right across here. And that can kind of almost trick you into thinking that maybe there's something kind of sinister hiding in the toward the apex of the right ventricle. And it's just the moderator band. So keep the moderator band in mind. There's a better look at it right there. Great. Okay. And I'll just decrease my depth a little bit. And then I can just pop the color Doppler on again. Just place it over the tricuspid valve. And again, we see a little whiff of blue coming back once in a while, just kind of varies with respiration as well. But as I mentioned, we see tricuspid regurgitation, a small amount on almost everybody. So considered, I guess, a normal variant, would you say, Dr. Cook?
Yes. Dime a dozen, see them all the time.
Great.
Well, thanks so much, Shelley. That was great.
You're
quick
welcome.
demo on showing how quick you can get a lot of assessment of the right ventricle. Keep filling the Q&A. It's getting really loaded up. We're going to get to it really shortly. We're going to hand it back over to Janez quickly, and then we will fill in as many questions as we can.
Thanks, Dr. Frankel. And thank you, Dr. Cook, for sharing your best practices with us today. And Shelley, thanks for the fabulous live demonstration. Before we open the floor to live questions with Dr. Cook, here's a quick poll. We'd love to help everyone continue on their journey in bringing POCUS to their practice. So do let us know if we can provide further information on our Clarius wireless scanners. Do click on as many options as apply. Pricing and availability does vary by region, so please feel free to request a quote and pricing. You may opt to speak to one of our experts about the advantages of wireless ultrasound. If you'd like to discuss scanner features, please select that option. You can also book a virtual one-on-one demo with our clinicians to see Claris HG3 in action in a highly interactive one-on-one session. And we can send you more video tutorials from our Claris classroom with physicians like Dr. Tom Cook. Please go ahead and select as many options as you wish. And while you complete the poll, I'll take a minute to introduce you to Claris HD3, the world's only third generation line of portable ultrasound scanners. Now 30% lighter, smaller, and more affordable, Claris delivers best-in-class wireless ultrasound imaging with an easy-to-use app that's powered by artificial intelligence for your app or Android devices. Our line of Claris scanners are specifically designed to deliver best-in-class imaging for a variety of applications. And today we're focusing on the phased array for superior cardiac imaging. With fast frame rates, the Claris PA-HD3 is amazing for rapid cardiac exams at the bedside. With a small footprint and deep imaging, the PA delivers high-definition window into the chest and abdomen for up to 40 centimeters. It's the leading choice for medical professionals looking for premium cardiac imaging in a versatile handheld wireless scanner. Also great for EFAST exams, lung evaluations, superficial and transcranial imaging. I also encourage you to request a virtual demonstration so that you can also see the Claris HD3 C3 multi-purpose wireless scanner in action for full body imaging. The secret to Claris lies in our design with 8 beamformers, 192 elements, and artificial intelligence that together deliver the image quality only found in compact systems, but at a fraction of the cost, representing about 85% savings. And with AI replacing complex knobs and buttons, it's as easy to use as your smartphone. Claris is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. It fits in your pocket, and you can get free movement with no wires getting in the way or touching your sterile prep area. With no wires, Claris is also much faster to clean and disinfect or fully encase in a sterile bag. Only Claris delivers wireless scanners with an ecosystem that includes a free app for your iOS or Android devices for unlimited users. Available with our new membership, Claris Cloud can be used to easily capture and manage unlimited exams from anywhere, or you can seamlessly save images and videos to your PACS server through the current DICOM web standard. Your membership also includes in-app Claris classroom videos with experts like Dr. Cook and onboarding with a clinician. And Claris Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. Available with membership or as a standalone purchase, the Primary and Critical Care Advanced package offers more flexibility for clinicians who need additional automated tools, specialized presets, and workflow solutions for common generalized scannings for EFAST, FAST, and whole body imaging. It includes the popular auto preset AI feature that streamlines workflows by automatically recognizing the anatomy being scanned and switching to the most optimized preset. We'll now close off the poll in 3, 2, 1. Thank you. If you ask for more information, we'll get back to you in the coming week. One additional poll, we'd like to invite you to pre-register for our final webinar in this series with Dr. Cook entitled Cardiac POCUS Part 3, Resuscitation Ultrasound. Go ahead and click Yes, sign me up to save your seat. And we'll send you an email confirmation in the coming days. I'll give you 5 more seconds to save your seat. 4, 3, 2, 1. We hope to see you there. I'd like to now welcome back our clinicians to answer your questions. Please use the questions icon in the menu bar to ask your questions. Dr. Frankel, I'd like to invite you to moderate, please.
Great. Let's just try and cram through as many of these as we can, Tom. First, do you ever do Vexus? Do you find it useful in ER?
No, I don't personally.
Yeah, I think I found it also. It's more of like for the internists and people in the hospital, I guess. Mm-hmm.
Yeah, it's a little too nerdy.
Well, now it's okay. There's nothing wrong with being a nerd.
Everybody would call me a nerd, so that's totally unfair. Uncalled for.
Yeah, uncalled for. That's right. How about if you see a clot in transit, what do you do? Do you just like reach for the lytics, or what are you doing?
Well, you can't reach for the lytics that fast, right? Like if it's literally you see it moving out of the heart, but you're gonna do a 3-ring fire, right? Like you're gonna call in everything you possibly can. If it's business hours, you're probably going to call over to IR and say, I got a pretty big problem here. If it's not, yeah, I'm gonna probably more often than not just give them lytics, assuming that they're physiologically deteriorate, right? If they become immediately hypotensive. Now, when you see that happen, I've seen it once or twice. The patients just go, "Oh, I don't feel very good," and they're out,
and they're unconscious. Yeah,
yeah. I mean, it's you never forget that clinical case, right? I remember one woman looked me straight in the face and said, "I don't want to die," and in the back of my head, I was thinking, "You're probably going to die," and she did. I mean, it was very dramatic. But I had one, no kidding. We shocked and defibrillated this woman 8 or 9 times, and she was 75. I mean, she was an old woman. I thought there's no way this woman can live. And lo and behold, she walked out of the hospital neurologically normal. And I went to her room and I said, "You remember me?" She goes, "No." I was like, I didn't say anything else. I felt like saying, "You died like 10 times." But I was blown away.
Yeah. I think it's going to be situation dependent. If you're living in a place that has IR, then you're going to call IR. If you're living on an island where everyone has to get shipped, if there's no IR, it's you and the patient, and maybe you've got the lytics and you do what you can, I guess.
Yeah, I mean, there's a freedom to it because they're dead, and
right.
you're like, okay, I'm going to try something.
Right. I guess we don't have to get into the weeds about. I think the question may have been like, if you see the clot before they crump, you see it like flipping on the valve. What do you do? Like, do you treat it as if it's already?
I think if it's flipping on the valve, you're going to give them heparin. You're going to get up the lytics, and you're going to. If it's me, I have that PERT team.
Right.
If I don't, I'm still just going to have the lytics ready to go. But I don't know that I'm actually going to give them until I see physiologic deterioration. There's clear evidence that helps. Mm-hmm. But if they're physiologically okay, maybe their lungs can take it and they'll do okay. But at least heparin. I mean, heparin's a no-brainer.
Mm-hmm. How about, you did a lot of showing on the parasternal and the apical views. Where does the subcostal view play for your right heart evaluation?
I practice in an area of the world where everybody's got a big belly. So it's hard to get. It's one of those times in some patients I can't, like, a classic is the COPD patient, the pink puffer with the big AP diameter. And they often have a great subcostal view, so I'll use it in them. Mm-hmm. But most of the time, I mean, the money for me is the parasternal and apical views.
Mm-hmm. Great. Why, I don't know how to answer this question. How come in acute CHF patients, POCUS is not used more in the ER? I think we all wonder that.
Really sure. I mean, I if a resident presents a case to me about that patient, and I'll say, they go through, I go, "What did the echo show?" And they'll say, "I didn't do it yet." It's like, why are you presenting the case to me?
Yeah, the value of that data is probably going to be a lot higher than the whole presentation.
Yeah. Right? In addition, half of them have pleural effusions. A lot of them have pericardial effusions.
Yeah, that was one thing we didn't really talk about today, was integrating, lung ultrasound. Maybe I'm skipping ahead to webinar number 3, but
that's resuscitation.
Yeah, sorry. I don't want to steal your fire there.
That's in April, folks. So that's my favorite lecture, by the way.
Okay, maybe last question is, you talked a little bit about assessing, chronic right heart pressure, say, chronic pulmonary hypertension from more acute causes. Do you do anything to kind of help evaluate the right ventricular preload and like how to manage them? Any tips on that in patients who are chronic pulmonary hypertension?
Chronic pulmonary hypertension, you mean isolated pulmonary hypertension?
I think that's what they mean.
Normal?
Yeah, I think they mean right side.
No one has a good answer.
Yeah.
Yeah, that's the problem with that disease, why it's terrible. Because the problem's in the pulmonary vascular bed. So, of course, you can try and give preload reduction, but what's happening there is that the left side of the heart's not getting filled. So the right side of the heart has too much preload, and the left side doesn't have squat, right?
Right.
So it doesn't work very well, and that's why these patients do just terrible.
Yeah. Lasix is like furosemide's a pretty blunt instrument for treating this like really localized issue.
Well, that jacked up right preload is what's forcing the blood through the pulmonary vascular bed to get to the left side. So if you drop right preload, that it just doesn't, the math and the physiology doesn't work out in that situation. It's hard. I mean, they don't do well.
Great. Well, I want to respect everyone's time. We got through most of the questions, but there's still a few left here. Sorry about that. We'll be following up with those, right, Janessa?
Yes, we will. Thanks for all of your questions and being so engaged in today's dynamic session. We did have dozens of questions. So if we didn't get to yours, we will get back to you in the coming week by email. You'll all receive a PDF copy of the slides, and we did record the session today, so we'll send you a link to the recording in the coming days. So please do keep an eye on your inbox. I'd like to thank Dr. Cook for sharing all of his best practices, and a very big thank you to all of you for joining us. We hope to see you again in our next webinar on April 20th with Dr. Cook on cardiac POCUS techniques for resuscitation. In the meantime, have a wonderful rest of your day and keep scanning. Thank you.
Thanks, everybody.
Thanks, everyone.